Hi, everyone. Welcome to the Preciska GU Tumor Board. My name is Brian Reaney. I'm a GU medical oncologist at Vanderbilt, and I'm happy to be joined today by a prestigious panel of experts from around the country to discuss several cases. I'm going to go around and have everyone introduce themselves before we get started with our first case, and I will start with Dr. Siegel.
Good afternoon. My name is Carrie Siegel. I'm a genitourinary radiologist in the abdominal imaging section at Washington University in St. Louis.
Thank you. Dr. Shaw?
I'm Chirag Shah. I'm a radiation oncologist at the Taussig Cancer Institute at the Cleveland Clinic.
Thank you. Dr. Abel?
Yes, thank you for having me. My name is Jason Abel. I'm a urologic oncologist, a surgeon at the University of Wisconsin.
And thank you. And Dr. Jakaki?
Hi, everybody. I'm Alexandra Drakaki. I'm a GU medical oncologist at UCLA. Happy to join you today.
Thank you all for being here. So we have several cases across the spectrum of GU cancer to discuss today. And we'll start off, and I'll sort of describe the case and the question, and then we'll go through some specifics of the case. And then I'll come back to all of you for an opinion, depending on what the specifics of the case are. Moving on to the next case, 71-year-old Caucasian male with de novo stage 4 prostate cancer and a low PSA. And the questions are about first-line therapy and whether that's affected by the low PSA on presentation. This patient presented with gross hematuria and worsening back pain over several months and fatigue, had a performance status of 2 when they presented. Medical history significant for coronary artery disease, recent non-STEMI and stents, ankylosing spondylitis and diabetes, 10 years smoking history, no alcohol or drug use, no family history. Cancer history late last year, had a CT urogram for gross hematuria, had a 9 mm sclerotic lesion at L3, a bone scan with moderate focal uptake along L3, an MRI of the lumbar spine showing an enhancing lesion in L3 measuring 1.5 centimeters, and then a PET scan with no avidity at L3 and no additional foci of disease. Dr. Siegel, this patient sounds like they're a radiologist's dream. They've gotten almost every scan that we know how to do to patients. And I guess I'm wondering, at what point do you stop scanning and do a biopsy? I mean, it's a fair question for you as a radiologist, and we do, I find this in prostate cancer. We do one thing, we do another, we're still not sure, and we do a third test, and we don't like to biopsy bone, but I assume at some point, I wonder when you recommend a biopsy as opposed to another radiographic image.
Well, I don't think that there's one right answer here. I think for me, when the 9 mm lesion went to 1.5 centimeters in a short period of time and was enhancing, I think for me, I would have at that point recommended a bone biopsy. So I don't know that there's one trigger point for radiologists. And it also depends upon how good your MSK radiologists are at biopsying these small lesions. But at many of our centers, they're very good at 1.5 centimeter and even 1 centimeter lesions. So I think for me at around that point, I would have recommended a biopsy. Certainly, when we get to the January of 2021, a whole year later, the lesion's gotten bigger.
Right.
So if we hadn't biopsied it in December of 2020, certainly at the next imaging point, this should have probably would go to biopsy.
Yeah. And I think we have some images coming up in a couple of slides. And I'm getting just, again, by the bottom bullet point here, this patient had multiple hospitalizations and cardiac stents. I'm wondering if the patient was kind of sick and in and out of the hospital, and maybe that was some of the reason that biopsy wasn't pursued, despite, sort of what we're seeing on the slide, which would make sense. But in January, they do get this CT-guided core biopsy of the L3 lesion. It's consistent with metastatic prostate cancer, normal for the markers that you'd expect. This patient gets, after they finish their cardiac issues in February, gets an MRI of the lumbar spine and has now this 3 centimeter L3 lesions, but now a right iliac lesion and an additional sub-centimeter enhancing vertebral body lesions. We'll see this on the next slide. Gets staging with a CT scan, chest, abdomen, pelvis that just redemonstrates the L3 lesion, but also now some additional bony lesions. Interestingly, PSA only 2.4. I don't know what it was previously. I assume a few months ago at the time of the biopsy result, it was checked as well, but is put on combined androgen blockade and gets palliative radiation to the L3 lesion. I guess maybe a question for Dr. Shaw. I'm not sure if this patient had symptoms in the L3 lesion. I'm looking back at the slides here to see if it was symptomatic, or maybe was it radiated just because it was growing in the face of everything else. I don't know if you have an opinion on, we struggle with this in terms of, maybe the question is, when would you radiate an asymptomatic lesion?
Yeah, it's a great question, and it's somewhat of a data-free zone in the sense that there is no perfect answer. But if I was seeing progression in the face of therapy, I would certainly consider if it's an area that can cause symptoms, right? So L3 is typically below the cord, so you're at the cauda. So spinal cord compression is typically falling away at that point. In theory, you're at risk of cauda equina syndrome. But I'm less aggressive in treating these patients unless they're having symptoms or there's risk of progression that could cause some kind of need for medical therapy. So, for example, spinal cord compression, progression to needing orthopedic stabilization and a weight-bearing bone. That's when I would typically be more aggressive in giving preventative radiation therapy.
Fair enough. This patient gets started on hormones, does get palliative radiation to L3, and we have their images now. And Dr. Siegel, if you want to just maybe describe what you see. I think even I could do this one, but I'll let you go.
Well, we have two sequential images showing a L3 lesion. The sagittal image on the left shows a lesion involving less than 25% of the vertebral body, and the middle lesion, the middle sagittal view, we can see it's involving more than 50% with significant increase in size of this. So marked progression over this imaging period of time.
Yeah, and I think this must have been the January and then April MRI. We don't have dates on here, but just sort of putting the story together. So the question is, what first-line therapy is recommended? Well, as I think happened in this patient, they appropriately got put on hormone therapy. I guess maybe the question, and Dr. Drakaki, I don't know if you have an opinion about, and what you standardly do about adding taxotere versus adding an anti-androgen like Abiraterone to these patients. And is this patient unique in any way, or would they fall in your normal group of patients that you would treat standardly?
Yeah. May I ask you how old is the patient?
How old?
Is it like in the 40s or 60s? Or
I think they were normal prostate cancer.
On the older
young. Yeah.
So back in the day, after the approval of taxane in the castrate-sensitive, I used to do Lupron taxotere in the first-line setting. In patients like this, actually, when they have oligometastatic disease, we often start with the Lupron, Abiraterone, Prednisone, and rescan in about 6 months. And depending on the response, based on imaging at the time, we offer radiation of the primary tumor and the oligometastatic sites. We have, again, a case series that we haven't published yet at UCLA, but that is very common the way we approach it. If patient has more widespread bone disease, they're very symptomatic, this is when I recommend chemotherapy first.
So chemo and more widespread bony disease, symptomatic disease, otherwise hormonal agents. I think I probably do the same thing. And then I heard you talk about radiation to the primary. I know there's a SWOG study. I believe it's a SWOG study that we have open that is randomized, if I'm not mistaken, for such patients to either give them local treatment to the primary, and I believe it can be surgery or radiation or not. Do I have that trial correct? Are you aware of it?
I'm not sure about the trial, but the practice of a radiation oncologist offer the primary and the oligometastatic only if there is low burden of disease.
Okay.
With the assumption if it's high burden, probably the benefit outweighs the risk from local radiation.
Dr. Shaw, do you want to comment? Do we know that radiating the prostate helps these people?
Yeah, it's a good question. And I think a lot of radiation oncologists, similar to what was mentioned, have combined a couple studies together. So when it comes to radiating the primary, we have STAMPEDE, which did show a benefit, albeit in those patients with, was primarily reserved for those patients with limited extent of disease. And that's a very specific definition. So it was 4 or more metastases, visceral metastases, or having 1 or more site outside the vertebral bodies or pelvis was considered extensive metastasis. So in any of those patients, there really wasn't that same benefit to radiating the primary. And you could radiate the primary either in 4 weeks or once a week for 6 weeks on that trial. And then separately is the idea of metastasis-directed therapy, which comes from, as I previously mentioned, Sabre, Comet, Oriole, and a few other studies. But I think in limited metastatic disease, a fair number of practices are combining those two studies and treating the primary and the sites of metastatic disease.
So do you think, if I have it right about this SWOG trial, do you think we still need to do a randomized study, or should we just be radiating primaries?
I do think we need a randomized trial because I think we're mixing and matching studies, which can sometimes be a bit dangerous, to be honest. So what I'd like to see is a trial that looks at basically primary and metastatic directed therapy at the same time versus not, right? It's a difficult randomization, to be honest, because most patients really want all of those things treated. So it becomes difficult to randomize patients. But if we really want to know the benefit, I think that's the way we have to head.
And I think the SWOG study allows for radiation to oligomets, but doesn't mandate it and doesn't randomize, if I have it correct. We have the study open, and I apologize, I don't know all the details, but I know it's randomized to primary therapy or not. So it sounds like, just to summarize, this patient sort of had a little bit of a winding road to diagnosis, got the L3 met irradiated, which could be reasonable. Dr. Shah was saying, certainly if anatomically critical or symptomatic, then it, I think, makes the most sense. And first-line therapy would be standard sort of androgen annihilation, if you will, probably not necessarily a need for chemo in this particular patient. And I don't think the low PSA, at least in my opinion, doesn't really affect the recommendation. I don't know if Dr. Jakak, you want to comment on that? To me, I wouldn't necessarily.
It's not a low PSA. Actually, another reason not to give Taxotere now is that, as you mentioned, he had dual antiplatelet therapy. So if we were to give him chemotherapy, drop his platelets, had to stop antiplatelet therapy, the risk of stent restenosis.
Yeah,
so more worried about his cardiac risk factors.
It sounds like significant cardiac comorbidities might limit his ability to get chemotherapy.